the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the personal and moments on the Hudson River line.
Just the last name of the date of birth.
How lovely.
First name.
Okay, let's get started. For those of you that don't know me, my name is Janet Blodgett. I've been here since the dawn of time, pretty much. I did all of my medical school, residency, fellowship, and I've been on staff for many, many years. So I currently work in the weight management and diabetes clinics. So I was asked today to kind of talk about a really practical approach to how to manage diabetic patients, mainly focusing on type 2 patients in the outpatient setting. So with no further ado, let's begin. So what I wanted to cover is kind of hit on the topic of really diagnosing the patients. We often see individuals that come to us in clinic and the primary care provider hasn't really identified, is this patient a type 1, is this patient a type 2, do they have diabetes because their pancreas is shot from recurrent pancreatitis, and that's really, really important to do, is really clarify the diagnosis, what to do at the initial evaluation, and the whole recent move to really individualize the treatment approach and the treatment goals for our patients. And again, most of this discussion is going to be talking about type 2 patients, which is the vast majority, of course, of what we see. And then also talk about pharmacotherapy, some of the current therapies, some of the older treatments that have new indications, and some of the new drugs, and also initiating insulin therapy in the outpatient setting. And our focus in our clinic is really on helping these patients, most of whom are obese, helping them lose weight. So we'll talk about that a little bit as well. So in terms of the classification, again, we often see the providers not really taking the time to determine what type of diabetes this patient has. The treatment approach is very, very different. Their sensitivity to insulin and other therapies is very different. So the traditional type 1 patient, we used to call them juvenile onset diabetics, but now we know they can be diagnosed at any age. I recently diagnosed type 1 in a 62-year-old patient. Those individuals are life-dependent upon exogenous insulin because they have usually an autoimmune-mediated destruction of the insulin-producing cells in the pancreas. The type 2 patient is a much more complicated disease. That's 90% or more of what we see here in South Texas. Those individuals have usually a strong family history. They tend to be obese. They're actually insulin resistant early in the course of their disease, and then their pancreases burn out and they become insulin deficient. And then there are the ladies that have gestational diabetes. 60% of them will go on as they age to develop type 2 diabetes. And then there are a miscellaneous category, and Dr. Copes this afternoon is going to talk about these individuals in greater detail, so I'm just going to mention them. Those are the maturity onset diabetes patients, those individuals who have primary diseases of the pancreas that become insulin requiring, and the rare causes of drug or chemical induced diabetes. So it's really a complicated label. And who should we test for diabetes? This is not new information, but we're not doing a good job of screening people here in South Texas. The screening requirements or recommendations are pretty much the same. So certainly anyone with a family history of type 2 diabetes, anyone over the age of 45, should be screened for diabetes. And it's much easier now because we can use the A1C test as a screening tool to make the diagnosis. So individuals that are obese, who are inactive, who have a first-degree relative with diabetes, ladies who have delivered a large baby that's 9 pounds or greater, or who were diagnosed with gestational diabetes, individuals with hypertension, and a big group of patients in this population are those people that we label as pre-diabetics, and we actually now have a medication we can use to treat these individuals. Those are patients with an A1C on previous testing of 5.7 or higher. and also conditions that are associated with insulin resistance. You see the acanthosis on the neck of obese individuals. Those individuals are very, very insulin resistant, and we certainly want to screen them for type 2 diabetes because they're high risk for disease. And also individuals with a history of cardiovascular disease, especially onset at a young age. So those are the same criteria we've had for many years, but we're not really screening patients adequately in this healthcare system. Okay, so how do we determine if a patient has type 1 or type 2 diabetes? We've got several biochemical tests now that make it much, much easier. For years we've had the islet cell antibody test, and that is a test that actually measures if the individual is making antibodies to their own islet cells. That test, however, is useful only early in the course of the disease, within the first 6 months after presentation or diagnosis. And that will be positive if the patient has a positive test that identifies them as a type 1 patient. We have a newer test that will remain positive a whole lot longer, and our laboratory does run the test. It's called a GAD65 antibody test. Again, if that's positive, that identifies the patient as having autoimmune mediated diabetes and they are insulin requiring. And that persists much longer than the islet cell antibody test. So personally, I don't really get the islet cell antibody test any longer because many patients come to us sometime after diagnosis and it'll be negative. And then there's a new test called the zinc transporter 8 autoantibody test. Our lab does not run this test, and I don't really see that it's any more useful than the GAD65 antibody test. So we have 3 biochemical markers that will help us identify a patient as having type 1. In addition, patients are likely to be insulinopenic or insulin deficient and require insulin to maintain their glucose if they've had recurrent pancreatitis, which is a common scenario in this population. I saw a gentleman yesterday, in fact, who'd had 3 back-to-back hospitalizations for pancreatitis and was insulin requiring. Individuals who have undergone surgical resection of a majority of their pancreas are going to be life-dependent upon exogenous insulin. And then there's a variant called a Flatbush variant, and we actually have a large population of those individuals in our insulin pump clinic. They're an insulin kind of interesting variant. They typically are African American. They have a very abrupt clinical presentation. They'll usually come in with a very, very high blood sugar level, oftentimes over 800 to even 1,000, and they're prone to ketoacidosis. But all of the antibody markers are negative on them. So they don't have an autoimmune mediated type of type 1 diabetes, but they are insulin requiring in order to live. So as I mentioned, type 1 is kind of easy. We give them insulin either by injections or through a pump. Type 2 is a much, much more complex disease. And part of the problem is for many years we were kind of ignoring the preclinical period. We were ignoring this time frame before the patient's glucose became really high and they came to clinical attention. So in type 2 diabetes, and this is a really well-known slide, what we see is around the time before diagnosis. Diagnosis is this vertical line here. Patients maximally express insulin resistance, and their pancreas is already overproducing insulin to try to maintain normal blood glucose levels. And so because they're overproducing insulin, their poor pancreas starts tuckering out. So currently, we label them as having type 2 diabetes at this point when their A1C is over 6.5 and their fasting blood sugar level is over 125, and they've already lost at least 40% of their beta cell mass. So I'll mention in a little bit that we now have the freedom to begin an effective medication, Metformin, in the pre-diabetic period. And that's really the first time we've had the official okay to start pharmacotherapy in this group of patients. My hope, and I think the hope of everyone that deals with these individuals, is that we can slide this diagnosis line back a bit and start being aggressive with treatment much before they have an A1C of 6.5. So insulin resistance is maximally expressed at the time we label them as a type 2 diabetic. They've already lost a significant percentage of beta cell function. And what we see in terms of their blood sugar level is initially an increase in their post-meal blood sugar level, not their fasting blood sugar level. So for those of you that are primary care docs in the trenches, when you diagnose a new patient with type 2 diabetes, don't ask them to check their blood sugar fasting in the morning. That's not going to be useful. Have them check it 2 hours after they eat, because that's when it's going to be highest. And that's when you can make treatment interventions in teaching them to limit carbohydrates and other things. So early in the course of the disease, the primary defect in terms of their blood sugar is actually 2 hours after eating. And then these poor patients with time go on to develop insulinopenia, much like a type 1. They become insulin deficient, but they remain insulin resistant. So they're still going to be responders to drugs such as Metformin that affect insulin resistance. So a very complex disease, and we'll talk a lot about clinical inertia, where many practitioners kind of don't make changes to improve A1C or glucose control until a year or two after the patients had a high A1C or glucose. So the diagnostic criteria have not changed. This is still the same approach, but we do now, and for several years, have been able to use the A1C as a diagnostic tool to label the patient officially as having diabetes, and that's been really helpful. So the diagnostic criteria are the same: A1C of 6.5 or higher, fasting blood sugar level of 126 or higher, or oral glucose tolerance test of greater than or equal to 200. And then the pre-diabetic period, which I wish we'd get rid of this category, are individuals with an A1C of above 5.7. And there was a recent study published which showed much increased risk of premature cardiovascular disease in individuals with an A1C of 5.8 or higher. And we'll talk about that in a little greater detail in a moment. Years ago, when we had a patient with kind of this borderline, we used to call it category, we told them, oh, don't worry, you're borderline, don't worry about it. And now we freak out, right? We say, you're high risk, you're destined to develop diabetes if you don't make some changes. So big change in attitude. Okay, the other kind of new thing, somewhat new, over the last several years is that treatment needs to be individualized, and we need to look at the individual patient, their age, their functional status, their particular set of complications, their psychosocial situation. Do they have good family support, or are they an elderly person living alone in a home with nobody around to help them if they have a low blood sugar level? So all of these factors now kind of allow us to individualize treatment, and for some elderly people who have cardiovascular disease and renal insufficiency, their optimal A1C may be 8%. And for a 20-some-year-old individual who is healthy and physically fit, it may be 6%. So that's been a big push in the last 5 years or so, is to really look at the individual patient, and their optimal A1C needs to be individualized. The other day I saw a young guy who's like 36, and he said, I was told my optimal A1C is 8. No. So this is a good idea if you use the criteria appropriately. And it's very heavily weighed on the age of the patient, obviously. So, but we have lots of people. I had a gentleman that lived with type 1 diabetes for 61 years. He died at age 92, and up till about 6 years before his death, he was playing volleyball with his grandchildren in the pool. And even shortly before he died, he walked faithfully with his walker around his assisted living facility, refused to go into a nursing home up until the end. So again, these are guidelines. These are not absolute, and you have to individualize what you do for the patients. Okay, and this is just a pretty slide. I had to show it. It pretty much emphasizes the same points about individualizing therapy, looking at the duration of their diabetes, the overall health of the patient, their set of comorbidities, particularly cardiovascular disease, and their social situation and their family support and other resources. Okay, so I thought long and hard about what I was going to say about this slide, and I believe, and I think Barbara Walls and other people that do this for a living believe too, that diabetes is a unique chronic disease. It requires, it's the only chronic illness that really requires that the patient be empowered and participate actively in controlling their disease. If you think about other chronic diseases, high cholesterol. My father was an Air Force vet, treated at Vandenberg Air Force Base in Northern California. He was put on a statin years ago, and he called me and said, my LDL is 100 and I haven't changed a thing I'm doing. So the statins are so effective in the lipid-lowering drugs that we can get patients to go without them changing their lifestyle. Same with hypertension. Salt restriction doesn't have a big impact on blood pressure. But all these new drugs that we have, drugs of different classes that work by various mechanisms, we can get most people regulated. But type 2 diabetes is tough to optimally control unless the patient is on board and an active participant. And so because of this, it kind of hit me like a sledgehammer when I was working with the SAIL group, that one of our proposals is to have a certified diabetes educator in each of the primary care clinics. And we presented this to the administration. I hope they'll be supportive. And that's RNCDE will work with a population of high-risk diabetics and help manage them. And he or she will be a resource to help with patient education and to help make sure if they have social issues that they get the proper assistance. So it really is a unique chronic illness, and the care model is a chronic care model. And so patients have to be engaged, and it doesn't work if they aren't. I saw a gentleman yesterday, he told me, I've made all the changes I'm going to make, I'm not going to make any other changes. There was no point in my arguing with him. He was very straightforward. He lost 34 pounds, he'd done a great job, but he'd done everything he could. He was actually tearful when I tried to press him a little bit. So he'd done what he could, and that was it. So it really is a unique disease. So how do you evaluate a new patient? So again, you've got to make sure you've got the disease state properly classified. Is this patient a classic type 1 with positive antibody titers? Is this a type 2 with tons of family members with diabetes? Is this patient a very, very brittle patient that's had their pancreas removed because of pancreatic cancer? You've got to clarify that information. And then evaluate the patient for diabetic complications, especially if they have typical type 2, because many of them will have complications at the time of diagnosis. So make sure they get the baseline retinal exam, check their urine for microalbumin, do a careful foot exam, and right now the SAIL diabetes team, in conjunction with the PAVE group, Prevent Amputations in Veterans Everywhere, is working to rewrite the diabetes foot clinical reminder, rewrite the podiatry consults, and hopefully get better access for our patients to podiatry care here. Our total amputation rate is quite high, and we're really trying to improve that. And we're also hoping that the CDE RNs in clinic can do foot exams to help unload the primary care docs on doing that. So then you formulate a management plan. Every patient should go to diabetes education. If they don't like being in a class setting, which many of our patients are uncomfortable with, they need to get one-on-one education. They need to be issued a glucose meter and the appropriate testing supplies. We see patients with meters but with no test strips or lancets all the time. And encourage weight loss. It's probably the single most, and we'll talk a lot about this, effective treatment for people with type 2 diabetes and smoking cessation. A diabetic patient that smokes increases their risk for heart disease 14%. So people with diabetes simply can't smoke. And then identify any psychosocial issues which may complicate their management. Years ago, I saw a gentleman, an older gentleman, always came neatly dressed to clinic, and he was very, very thin. His diabetes was poorly controlled. And I asked him, how are you eating? And he started crying. And he said, I don't have any money. I don't have any money to eat. And so I linked him up with Meals on Wheels. And it was that simple little effort really changed his life. And he came back, he gained a few pounds, So make sure you assess those psychosocial issues as well, because many of our patients have significant issues. Okay, so the physical exam, most of the heights in our system are stated heights, and most every male veteran I see says that they're 6 foot tall, even those that I look straight in the eye. I'm 5'1". And so actually take a few seconds to measure their height, get a weight, and tell them what their body mass index, have them start tracking that. A good blood pressure initially in both arms. An oral exam, periodontal disease can lead to high glucose levels, and the dental school next door is very, very active in doing periodontal research in patients with type 2 diabetes. So I've sent lots of patients over to the dental school, and they get free exams, many of them get free cleanings that they can enroll them in clinical trials. Check the thyroid gland, give a feel of it. Hypothyroidism is much more prevalent in individuals with both type 1 and type 2 diabetes. Do a careful cardiac exam and an evaluation of the skin, acanthosis and insulin injection sites. Patients hate it when I tell them to pull their shirt up, because I look to see if there's any bruising on their belly. And even if patients have good injection technique, they'll have some bruising occasionally from their sub-Q injections. And then a comprehensive foot exam, feel the pulses, do the monofilament testing, and also deep ankle reflexes. Technically, that should be done at least once a year, but it'll be great if we get these nurses to have more eyes on the feet of our veterans. Okay, so I ran into this quote and I thought, wow, this is really cool. So this is an actual statement from Hippocrates, and I guess it's actual, I don't know how you prove it. But I thought way back then, he had it all right. So his statement, if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we could have found the safest way to health. And I think that's really, really true. And so our effort in weight management clinic is really to focus on making the patient healthier, getting their weight down, which will really make a difference in terms of their diabetic control. So one reason I recommended the CDEs in our clinics is where we're failing our type 2 patients is we don't have the time to do therapeutic lifestyle education. And that's the single most effective treatment for individuals with type 2 diabetes. And there's an abundance of evidence proving that. These are all kinds of clinical trials just simply with lifestyle change, exercise, limiting calories, and these are all kinds of trials on pre-diabetic patients using various drugs, including Metformin, the first glitazone, which was troglitazone, which is actually a great drug, acarbose, which is a drug that blocks carbohydrate absorption in your gut, but makes you real gassy, and then the tiglinide and valsartan, the Navigator trial that Steve Hafner at the med school next door had, was director of that trial, and that used tiglinide, which is a insulin secretagogue, and valsartan as a blood pressure pill. So lots and lots and lots of studies showing that simply lifestyle change or just a single medication, diabetic medication, can have huge impact on delaying the progression of this big population of pre-diabetic patients to frank type 2 diabetes. And this particularly is where we're failing here. You know, we don't have enough people to do the therapeutic lifestyle education piece of this effort. So one of the biggest trials and one was the diabetes prevention program, and Dr. Hafner was a big researcher in that, and I think San Antonio had one of the biggest study groups for this trial, and it was a landmark trial. It was a large trial, over 3,000 men and women with pre-diabetes, and it was defined by the usual criteria. They were randomized to different categories, either purely lifestyle, and they had really intensive care. They had dietitians, they had physical therapists who worked really, really closely with these people. It was very costly. They achieved a target 7% weight loss and exercised 150 minutes per week, which is what the recommendation is. And then the second group was on Metformin, 850 milligrams twice a day, or they were on placebo, which means they had some education on therapeutic lifestyle change, but no anti-diabetic med. The primary endpoint was how many of these people converted to type 2 diabetes. They were followed for an average of 2.8 years, but the study was was concluded prematurely because the results were so compelling. And this is a little logo from the DPP program. So the placebo group, no surprise, did the poorest. They had the highest % conversion over just under 3 years to type 2 diabetes. The second group, and they had a 31% lower risk of conversion, were those individuals treated with metformin alone. And the group that did the best was the group that had really, really intense therapeutic lifestyle change education. They had frequent visits, they had it frequently reinforced, they lost weight. 7% is a lot. Our bariatric patients, we require them to lose 5% before we consider them for surgery. 7% is a lot. They did the best. They had a 58% reduction in converting from prediabetes to frank type 2. No other drug will do that. And so this is really, when I wrote the proposal for the CVEs, this is how I justified it, is we're missing this whole piece. We've got to encourage that. And so the data, they're still following some of these people years later that were enrolled in the DPP trial. And what they found, that those individuals that had intensive lifestyle change, who were successful in losing weight, or given metformin, reduced or delayed the development of type 2 diabetes as long as 15 years. That's huge.
Yeah.
So because of the reevaluation of this data from the DPP trial, finally, we have the recommendation to treat patients in this pre-diabetic or borderline diabetic group with metformin. So the recommendation now is to use metformin in those individuals with impaired glucose tolerance, with isolated impaired fasting glucose intolerance, or an A1C of 5.7% or higher, 5.7 to 6.4. Remember the other study that showed individuals with an A1C above 5.8 were at increased risk for heart disease. Metformin is a super drug. It does lower the risk of cardiovascular disease. It prevents conversion of prediabetes to diabetes. It has anti-cancer properties, which the National Cancer Institute is reviewing. Affects multiple cell lines. It's a great drug. Actually took it a couple times. I thought, all these patients say they get diarrhea with it, and I did. I couldn't believe it. I just took about 500 milligrams, and I couldn't tolerate it. I was so mad. It's a great drug. Couldn't believe it. All right, so unfortunately, this other study, and you guys are really current, this was published this year, Annals of Internal Medicine, this year, just a couple weeks ago. This study showed, are we using metformin properly? Are we giving it to patients? And so a national sample of over 17,000 patients was conducted by a couple insurance companies. And they found that only 3.7 of patients with the official diagnosis of prediabetes were given metformin. Pathetic. So the conclusion was, evidence shows that metformin is rarely prescribed for diabetes prevention in working age adults. So hopefully now we'll start using it, because it really works. And this is a big problem in this system. I think everybody, especially in the primary care clinics, they're just so pressed for time. If the A1C is under 6.5, they don't deal with it. Yesterday in weight management clinic, I had 2 individuals. I had to tell them they had type 2 diabetes. I had 2 people, a lady with an A1C of 6.5, she cried, and a gentleman with an A1C of 6.7. I had to tell both of those people, you have diabetes. We had to do the whole routine in clinic, and they had those levels for quite some time. Okay, so how do we treat these people? We talked a lot about therapeutic lifestyle change. It really, really, really works. We'll talk a little bit more about it. Oral therapies, injectable agents. There's some newer non-insulin products, how to initiate insulin. So let's get started. Okay, so this is a slide of, and it's getting busier and busier as we get more oral therapies. And so we have lots of different oral therapies who have different effects on controlling blood sugar levels. So we can really pick and choose. If you have the patient measure their sugar at home before meals and after meals, you can find out Does this person have mainly a defect, and after eating their blood sugar levels go really high? Are they high all the time? So that you can really tailor the therapies precisely to your patient's glucose levels. And they work by different mechanisms. In my opinion, and you'll see in the different slides you're about to see, metformin should be given to every patient with type 2 diabetes unless they have a contraindication. Or like me, who doesn't have diabetes, can't tolerate it. And there are some new agents. So what is the optimal oral agent? The optimal oral agent needs to be effective. It needs to have significant A1C lowering effect. It needs to be durable so that the effect on type 2 diabetes control is going to last for years. It needs to have a low risk of hypoglycemia or other adverse side effects. It needs to be convenient to take. And so what's the class of drug that fails in those features more than any other group? The old sulfonylureas. And most endocrinologists don't use those anymore because weight gain, you don't want a patient to gain weight, they become more insulin resistant. They cause hypoglycemia. You have to time it with the meal. That's not terribly convenient. And they don't have durability in improving blood sugar control. And they do accelerate beta cell burnout. They do accelerate loss of insulin producing ability from the pancreas. So the sulfonylureas, many, like me, many endocrinologists really don't use them anymore. They're really not, they're obsolete in my opinion. They're dirt cheap, but they're not very effective and certainly don't last very long. And anything that's going to accelerate beta cell burnout is not a good drug in a type 2 patient. Okay, so this kind of looks at the different options, and again, the sulfonylureas really, in my opinion, really, if you have any other options, really shouldn't be used anymore. There's always been issues in terms of cardiovascular safety, and it seems to be related to changes in potassium, much like we see with insulin. But their benefit is that they're low cost. So I don't like using them. The TZDs, we had troglitazone followed by rosiglitazone and pioglitazone. Rosiglitazone is pretty much out now, so we're left with pioglitazone. For appropriate patients, these are great drugs. One of the studies done on preventing conversion of pre-diabetics to type 2 diabetics was a study done using one of the glitazones. So I like them. You do have to watch patients for peripheral edema, weight gain, and those that have a history of decreased left ventricular function might be at risk for CHF. But if you keep the dose lower in the moderate range, they do very well, and they're effective for years and years and years. They have excellent durability in controlling the blood sugar level. There's been an issue with pioglitazone and bladder cancer. You see lawyers on TV saying if you've taken pioglitazone and you and your family member have bladder cancer, give us a call. But in appropriate patients, they're good. The newest kids on the block are the SGLT2 drugs, which block resorption of glucose, so the glucose is lost in the urine. And the main side effect of these agents is yeast infections, genital yeast infections, some increased risks for urinary tract infections. Also, they cause patients to urinate more. So if an individual has a relatively low pressure and they're almost like a diuretic, they can have some issues with postural hypotension, and they're costly. The DPP-4s are oral therapies, and I'll show you specifically the different agents in this group. There's some new concern over risk of congestive heart failure. There is a risk of pancreatitis with both the DPP-4s and the GLP-1 agents. And they're very high cost, both of these. This is an oral drug, this is an injectable drug. But again, in the right patient, it may be a reasonable option, and they're fairly effective. The GLP-1 drugs, there was one recently approved specifically for weight loss, and we'll talk about that. They're given by injection, much like the DPP-4 drugs, like sitagliptin. These drugs have a risk of pancreatitis, and if a patient has a history of pancreatitis, you should not give them either of these classes of drugs. And then there's good old insulin, and the problem with that is hypoglycemia and weight gain, and it also has to be given by injection. It's not as costly as some of these new oral therapies, but these side effects are a problem, especially the weight gain. So really, diabetic treatment in terms of pharmacotherapy has gotten really, really complex, but consistent protocols recommend metformin, and I do know that the PharmDs here are looking at the charts of a lot of patients who have high A1Cs and making sure that everyone that can be on metformin is on it, and I think that's a good strategy. So years ago, we would always have everyone on sulfonylurea and metformin, but now it's really tailored. Maybe a thiazolidinedione, pioglitazone is the one to add. Maybe saxagliptin is the DPP4 here we have. We don't have access to the new class at all, probably another decade before we do. And then the GLP-1s, I have been able to get those for a couple of patients, some of the injectable drugs, especially if you have a patient who has a commercial driver's license. They can't take insulin, but they can take some of these other drugs. So really, really, and then we can use good old basal insulin with metformin. That works great. So lots of different combinations and options. And we even go to triple therapy, and again, it needs to be individualized. It's very complex. And this is just another example of the different approaches. So the GLP-1s are the injectable drugs, like Byetta and Victoza. You see all the ads on television for Victoza. And they're pretty neat because they can cause weight loss, which is a great side effect in people with type 1 diabetes. So how do they work and why are they so effective? So these drugs blunt glucagon secretion, and we forgot that type 2 diabetes is a high glucagon state. It's like when this class came out a couple years ago, I went, oh yeah, that's right. I remember from my physiology days, the type 2 diabetes is a high glucagon state. We haven't been dealing with that for years. Well, the GLP-1 drugs blunt glucagon secretion, and that's another way of improving both the fasting blood sugar and the blood sugar after eating. They're also glucose-dependent insulin secretion, and that's why the glutinides like Starlex are better than the old sulfonylureas like glipizide, because it's an on-demand insulin release. And that's what these drugs do. So if the patient's sugar level is near normal, it's not going to stimulate insulin release. And then they affect gastric emptying. And if you can slow gastric emptying, which these drugs do, people don't feel hungry so frequently. And they have a lessening of the postprandial blood sugar spike. If you absorb food really quickly, a high carbohydrate meal, your blood sugar peaks really high. And if you delay gastric emptying, you're going to have a blunting of that postprandial blood sugar elevation. And they affect satiety because of the delay in gastric emptying, and that's how these people lose weight. So very effective agents, injectable agents for type 2 diabetes. And then these are the changes when different classes of drugs are added to metformin. And again, the universal recommendation is metformin needs to be the first drug. It needs to be left on board until the patient has a contraindication to using it. I still see primary care providers stopping all oral therapies when they put people on insulin, and that's a no. So the A1C reduction obviously is going to be greatest when you add insulin, and less when you add agents that, like the DPP4s in this population, it's saxagliptin, which aren't as potent in terms of A1C reduction. And then weight, makes me really frustrated when I see these people. Like I had a lady this morning came to me, 52 years old, her body mass index was 52. She was as round as she was tall. A1C was 12.7. She was on 160 units of insulin and wondering why she couldn't lose weight. So, insulin is a real problem. So you really have to think when you're prescribing drugs, what's the impact going to be on this individual? So cranking up her insulin dose up and up and up wasn't good for her. She gained a ton of weight in a very short period of time. So we're thinking of other alternative therapies for this lady that aren't going to cause her to have such a great weight increase, and also teach her things. about, and I'll show you something else in a moment about what she was doing. So you really want to also choose the add-on agent to metformin in terms of what the effect it's going to have on a patient's weight. And the sulfonylureas and pioglitazone are going to make them gain weight. If they're on Byetta or Similan, they're going to lose some weight. So you have to look at the whole patient, not just at their A1C, but also at their body mass index when making a decision on their treatment. Okay, and these are the different GLP-1s. It's just exploded. These are injectable drugs that have the effects on gastric emptying, satiety, insulin release. And so we have a whole spectrum of them now. And the new news for weight loss is that this particular one, Liraglutide, has been recently FDA approved in a higher dose for treatment of obesity, and I'll show you that in just a moment. So we're kind of overlapping treatment of obesity and diabetes a whole lot. Then also look at the therapies in terms of their effectiveness. The most effective oral agents in terms of A1C lowering are going to be the biglonides. In this country, the only one we have is metformin. Thankfully, it's the safest. And the darn sulfonylureas. For a while, they're very effective. They may lower the A1C as much as 2%. They're followed by pioglitazone and then drugs like Starlex, which is formulary here. And then some of the newer agents, unfortunately, like saxagliptin, are not terribly effective. Only A1C reduction of 0.5 to maybe 1% and are very costly. Okay, so these are some of the injectable therapies other than insulin for type 2 diabetes. We have limited access to these in the VA. There's exenatide, which is available in several forms. Byetta is twice daily, and Bydureon is taken weekly, which is very convenient. And these agents enhance insulin secretion when it's needed. It's on demand. They decrease hepatic glucose production and suppress appetite. So use of these exenatide drugs will result in weight loss usually, and it can be quite significant. Liraglutide, also marketed as Victoza, you see all the ads on TV. There's lots of ads on TV. Has the same effects on glucose, and I'll mention in just a moment, it's been FDA approved in a higher dose for treatment specifically of obesity. It's the newest obesity treatment drug approved. And then there's Similan, which I've actually had quite a bit of success getting approved through pharmacy here. Works by similar mechanisms and works very well to control post-meal blood sugar levels, and patients can have significant weight loss. I have one young lady that lost 50 pounds. So she takes Similan before her meals and either skips the Novolog or takes half of the usual dose. So you can really reduce the amount of insulin and achieve better glucose control with less insulin, and they tend to lose weight. Okay, so what's clinical inertia? Clinical inertia is a big problem here at the VA. Clinical inertia is when clinicians are stuck and don't initiate or intensify or change therapy. I saw a patient in diabetes clinic recently that I'd seen 3 or 4 years earlier, and he came back to me on exactly what I had him on 3 or 4 years ago, and in the meantime, what happened is A1C went up. So clinical inertia is a big problem, and some of that is just because of the time pressure in the primary care settings. So it's a big problem in diabetes management because diabetes care is very, very time intensive. So a study was actually done on that, clinical inertia in people with type 2 diabetes, or this retrospective cohort study of more than 80,000 people published in Diabetes Care. Conclusion, no surprise. A substantial proportion of people remain in poor glycemic control for several years before intensification with either oral anti-diabetic drugs or insulin. So people tend to get stuck, and that's really, really common in this population. Okay, so it affects at least a third of all patients, and it's greater in those people who are newly diagnosed, and that's the time when you want to be most intensive. You know, you want to really get their A1C down and get them well controlled at the beginning with a drug that's going to protect their beta cell function. And so usually providers don't make a change until the A1C is 1.4 points above their target, and that's really too late. And that again is a fairly recent publication. Okay, so starting insulin is very difficult in the outpatient setting. It's very, very time intensive for the provider, and you get a lot of resistance on the part of the patients. So it wasn't really insulin. You don't have diabetes yet. It was just a warning shot. So I thought that was pretty fun. Okay, so when should we start insulin? If the A1C is over 8 and a patient on 2 or 3 oral therapies, it's time. Or in patients, even newly diagnosed, when they come to you with a really, really high A1C, you may be ferreting out, is this a type 1 or type 2? Well, it takes about 2 weeks to run the GAD antibody test. You don't want to send that patient out without some insulin, so you may want to start it in those people that are newly diagnosed, even if they're newly diagnosed with a very, very high A1C. And then you can always taper it off as they come under control if they're proven not to be a type 1. Okay, what are the barriers? This is old stuff. These are the same barriers for initiating insulin. And they're barriers on both the side of the provider and on the side of the patients. For the provider, it's lack of resources. There isn't somebody to teach the insulin injection. And I saw a patient this morning, I'll tell you about in a minute, who was diagnosed in 1999 that was not injecting her insulin correctly. So there's lack of resources to do the initial teaching, and that's key. That's why the CDE and all the primary care clinics would make such a difference. And then there's not the time to bring them back in a timely fashion to see how they're doing on insulin, see if they're compliant. And then patients are really resistant. I've had them cry, I've had them yell. When they find out they have to take an injection, there's all kinds of fears. Years ago, it was very common in the population I used to see downtown that patients thought that meant the end was near. If I'm starting insulin, they're going to lose their leg, they're going to go on dialysis, and they might as well go home and die. And so there's all kinds of misunderstandings on the parts of the patient. And then there are real concerns. One of them is weight gain and also hypoglycemia. So that means you have to do, when you start insulin, you better teach the patient how to treat hypoglycemia. That's more time. And then obviously, optimal control oftentimes is going to require multiple injections. Okay, so it's much easier now because we have so much better insulins. The new basal insulins, Glargine and Detamir, I prefer Glargine, I think it's a little flatter, are wonderful insulins. They're really, really great. They have a much lower risk of hypoglycemia. They're oftentimes extremely effective just as a single shot once a day. But patients have to be taught how to inject correctly. And so these are the action profiles of the different insulins that are available to date. And this is Lantus or Glargine, and that's why I like it. In my opinion, it's the only, and I think most endos agree, it's the only truly flat profile insulin. It does have a little bit of a peak when you first inject it. That's why I typically will give it first thing in the morning. Detamir or Liraglutide has a bit of a peak. It does tend to last close to 18 hours in most people. It's not truly a 24-hour profile insulin. Most patients have to take it twice a day. NPH is a peaking insulin. They better have carbohydrates on board when that insulin peaks or they're going to have a low. And then we've got the new rapid-acting insulins, which are what we typically use for most of our patients on multi-dose regimens. These guys really peak fast and they clear fast, so timing with the meal is essential to avoid a low. Yes?
You use two different types of insulin? Like, can a person use two different types of insulin? Like, you know what I mean?
Uh-huh.
For example, I've heard of someone who has, in the daytime waking hours, they'll take Humalog, but at night they'll do the Lantus one.
Yeah.
If
someone has a fairly high A1C, they're probably going to need both a basal, like Lantus or Liraglutide, and a pre-meal insulin. Depends on how high their A1C is. But usually most patients that have type 2 a long time are going to need a multi-dose insulin therapy, which is exactly that, a combination of a basal and a premeal. So we really can pick and choose. Regular insulin I use mainly in individuals that have gastroparesis, where they don't absorb the food normally and need an insulin that's not going to peak quite as quickly. But you can see if you take this insulin 30 minutes or so after you're eating, you're going to have a hypoglycemic event because it peaks so rapidly, patients are going to get in trouble. So that's where education is really key at the time you prescribe this insulin. So when you do diagnose insulin therapy or do prescribe insulin therapy, you have to teach patients how to inject, you have to teach them about storage, shouldn't be in your car, exposed to temperatures above 86 degrees, the timing with meals. And we do now have ready access to the pens for rapid-acting insulins. Many of our patients don't eat at home, they eat away from home. And so they need to have that insulin readily available when they're eating outside the house to take. And then also teach them about hypoglycemic management. So the lady I saw this morning who had diabetes since 1999 was injecting right here, right around her belly button, and that's where you should not inject. And so she started crying. She said, well, I'm trying to do what I was told, and she had misunderstood all these years, so she's going to change her injecting. So all of those things make a big difference. Injection technique is really important. Lantus is the only insulin that has studies that show it can be injected at sites other than in the abdomen. It can be injected in the thighs or the arms. Okay, so I'm running out of time, so let me just mention a few things with metformin. The drug I couldn't take, but everybody else should. It's been really freed up. We used to be told, don't give it to a woman with a creatinine over 1.4 or a guy with a creatinine over 1.5. Not the case anymore. It's an old drug. There's been decades of experience with it. It's now based on the creatinine clearance, not on the serum creatinine level. So it's really freeing up the number of patients that we can give metformin to. So you really don't have to reduce the dose until the creatinine clearance is less than 45. And then between a creatinine clearance of 30 to 45, you can give them 1,000 instead of 2,000 a day, and don't use it in individuals with a GFR less than 30. So this is really going to increase the number of patients that we can give metformin to. Okay, and then these are the new class of drugs. I'm just going to briefly mention them. The SGLT2, sodium glucose cotransporter 2s, or the gliflozins. And there's a whole bunch of them, and they even come out with combination pills with metformin, of course. And those are the drugs that are modestly effective, but work by a totally different mechanism through the kidney, preventing glucose resorption. Main side effect is yeast, vaginal yeast infections in women, urinary tract infections, and hypotension, because it is kind of a diuretic-like property. Okay, and I just wanted to briefly mention some stuff about obesity. The most effective treatment, as I've mentioned over and over and over, is therapeutic lifestyle change. It is estimated that half of all diabetic cases could be eliminated if weight gain could be prevented. So San Antonio was just last week rated in the top least healthy cities in the country. Did you guys know that? And that's based largely on the density of fast food establishments in the city. Because if there are all these fast food places and they're in business and doing well, people are going there to eat. And we do, we go there to eat. So diabetes has increased dramatically over the past 20 years. That proves that diabetes is caused by global warming. So it really is, diabetes is the comorbidities of diabetes and obesity. And very quickly, weight loss between 5 and 10% is a huge impact on improving A1C and reducing the risk of people with prediabetes converting to full-blown type 2 diabetes. And there are examples. Drew Carey lost over 80 pounds through therapeutic lifestyle change only. He did not have bariatric surgery, and he's maintained it, which is really surprising. And that's the main problem, is sustaining the weight loss that we see is an issue, but he's done very well. And this is Liraglutide, has been remarketed as Saxenadide or something like that, I don't know. And it's a more potent liraglutide, which is a GLP-1. So it's a 3 milligram dosage. The dose to treat diabetes is 1.2 to 1.8 milligrams. So this is a higher dose of this GLP-1, specifically indicated for obesity treatment. So that's kind of twisting a diabetes drug to use it in obesity. Really, really clever. Okay, and then I just wanted to mention bariatric surgery. In the endocrine literature, it's exploding with bariatric surgery as a treatment of type 2 diabetes. And this was the cover article of Endocrine Today, April 2015. Bariatric surgery enters the mainstream for treatment of diabetes, and it really is very effective. And there's an abundance of data in the literature showing that diabetes goes into remission as quickly as a year after bariatric surgery. And like the day after, or a couple days after, I usually can stop basal insulin. It's just remarkable, absolutely remarkable. And it seems to be an issue, and it's different. The success with diabetes control is different depending on the different bariatric surgeries. So the big boy, the Roux-en-Y, where we make the stomach very small, staple it off, and bypass the first part of the small bowel, you're going to get as much as a 2 per, the A1C normalizes after bariatric surgery. And with a sleeve gastrectomy, where the surgery moves up to 75% of the stomach, the A1C approaches normal in this particular study. And pretty good results also with the adjustable gastric band, which usually will give you the least in terms of weight loss. So it really works. So if you have a patient who's morbidly obese and their diabetes is poorly controlled, it really is being used quite widely as a treatment, and it saves their life. Okay, and this last slide just shows, it's a widely used slide in bariatric centers. It shows the overall benefits of weight loss, be it through bariatric surgery or intentional weight loss. And I think what's most telling is overall mortality, 89% reduction in 5-year mortality, and in terms of cardiovascular risk reduction, 82% risk reduction in cardiovascular disease. Type 2 diabetes, 83% risk reduction. There's no handful of pills that we can give patients that's going to have this type of an impact. And I'm going to leave it at that. I know I'm out of time.
Questions? Awesome.
You said that liraglutide was 1.2 to 1.8 for diabetes.
Right.
Are you using, or are they recommending maybe increasing it for diabetics that need weight loss and then bringing it back
Well,
down?
I think you can write it as an indication for weight loss with the 3 milligram dose.
Okay, and then I think the other question was, you said metformin. There, the EFGR, it has to be at least 30.
Yes,
That's a change, right?
that's changed.
Okay, on some of the newer drugs, those are, the EGFR has to be higher, correct? It has to be at least 60? Okay, all right.
Yeah, and our
that's my answer.
pharmacy hasn't, the pharmacy alerts haven't quite caught up. This morning I had a patient, I was renewing metformin, it said no creatinine level in 30 days, and of course all that now is.
Okay, thank you.
My question is about the pre-diabetic. Why isn't it better if you're pre-diabetic to try to do the lifestyle changes to get the numbers down?
Oh, you do that, absolutely.
Well, but you're saying that doctors are now prescribing metformin right at that
Yeah,
point.
you do both. You always do TLC, you always do therapeutic lifestyle.
But once you start metformin, you can never stop it, right?
Sure you can.
Oh, you can?
These are, yeah, you could, but these are really high-risk people who are.
No, but I mean, if you're pre-diabetic,
Right,
you can take metformin, when the numbers go down and you can stop it?
theoretically, yes.
Theoretically. Okay, thank you.
I know, speaking of the metformin with pre-diabetes, do the insurance companies pay for it if you don't actually have a diabetes diagnosis?
I think they're going to have to. I think it's depending upon the insurance companies, but I think they're going to have to, and I know some are.
And then my other question was about the drugs like Invokana. I thought it was weird when I saw that those were coming out because I was always under the impression that one of the reasons diabetic patients get nephropathy is because they're filtering all the sugar out in their urine.
Right.
So doesn't Invokana increase that risk?
No, it doesn't. So, the usual renal threshold for glucose going into the urine is about 200, the usual threshold. So Invokana and related drugs change that threshold. So you get you get glucose lost in the urine at a much lower threshold. So it doesn't increase your risk for nephropathy.
Okay.
There is some concern over the risk for DKA, and that was just very, very recently mentioned, and I don't know the details, and I don't know why ketoacidosis is a concern, but it's an observation at this point. I don't think the rationale behind that is known yet.
Okay, and then my last question is that I have always heard endocrinologists, CDEs over the years claim that the fact that you would gain weight on insulin is a myth.
No, oh no.
Yeah, I mean, I always read in the medical literature that, oh yes, it causes adipose tissue to form, but then you go into the CDE and the doctor and they're like, oh, that's a myth, you won't gain weight on insulin.
Lots of bodybuilders and stuff use insulin to bulk up. You know, that's no myth, that's very real.
Any more questions? Any questions? Any more? Okay, that's it. No questions? Thank you. Thank you so much, Blodgett, for that great presentation. Okay, now it's time to refuel on your glucose and sucrose and
Low carb.
glycogen. We got some high sodium protein in the back. We're going to get in line, and we're going to resume our next with our next speaker at 1 o'clock sharp. So 1 o'clock, come out to hear Dr. Moose's presentations. Thank you.
Radiant, swingy hot motor trip, burning toast.
I usually start 500
And moments on the Hudson River line. How lovely it was. Many's the time that we feasted, and many's the time that we fasted